Welcome everybody to today's Grand Rounds. It's a pleasure for me to introduce Dr. Rebecca Rivera, who is a postdoctoral fellow in the Indiana Public and Population Health Informatics Training Program that Brian Dixon and I co-direct. Rebecca is no stranger to many of you. She's presented at what used to be the WIP several times. You've heard her talks about Health Start, and more recently about food insecurity. Today, Rebecca will tell us a little bit about her ideas on what we could potentially do for or about food insecurity in the clinical environment. It builds on research she's done in nutrition education, and it is also the topic of her planned K application that we are working on very intensively. So I'm looking forward to copious comments from everyone in the audience, you can ask questions at any time. I would like to ask you, when you have a question during the presentation, just put it in the chat. I committed to monitoring the chat for Rebecca, and I'm going to chime in with questions as they come in, and then we'll have time for questions at the very end. So with that, let's get started. Rebecca, it's all yours.
Thanks, Titus, for that nice introduction. I'm just going to share my screen. There we go. So thank you, everybody. Good morning. Welcome to my talk today on food insecurity and how we might approach this public health nutrition problem in the clinical setting, specifically in primary care. I have a couple learning objectives for you. First, describe the relationship between food insecurity, nutrition, and poor health outcomes. I really want you to be able to understand the link and how those work together. Second, explain how and why nutrition education is an effective tool to reduce food insecurity. Third, praise your own clinical setting. So for those of you who are clinicians, I want you to think about when you're caring for patients, how can you start to implement and address approaches to food insecurity? And there'll be an opportunity later for some discussion around that point. And then finally, we'll need to assess and acknowledge some of the facilitators and barriers to addressing food insecurity in the clinical setting. Here's just a brief outline of what I plan to cover in my talk today. So a lot of you I know have been at some of my talks before on food insecurity, so you're already familiar with the topic, but I want to catch everybody up to speed. And also there's some new data, and I want to present some things in some new ways. So that hopefully will be interesting to you. And then we'll kind of cover some of these other topics to address the learning objectives. And then at the end, I'd like to discuss my Career Development Award that Titus mentioned that we've been working on. And finally, open it up for questions and hopefully a lively discussion and lots of feedback from all of you. So shown here is a breakdown of the definition of what food security and food insecurity is. And instead of going through all of this, I actually want to illustrate food insecurity with a little bit of a story that a fellow predoctoral trainee in the Population and Public Health Informatics program shared with us about a month ago. So this fellow was living in New Orleans, right in the heart of the city, didn't have a car, so depended on himself to walk to the grocery store to get food. He decided one day that he really wanted some fresh fruit. He wanted an apple. And so he walked out of his building to the closest food outlet, which is more like a convenience store rather than a grocery store that a lot of us are familiar with. Convenience store did not have any apples. Actually, the fresh fruit there was basically non-existent. So he thought, no big deal. I'll walk over to the next convenience store and get an apple over there. No luck. He was having a hard time. He's walking around to all of these different stores, and none of them were meeting his needs until he came across the last store. And they had a bag of apples, not just one apple, a whole bag of apples. And so he was excited until he looked at the price and got sticker shock. This bag of apples was more expensive than what you would expect to pay at an organic grocery store like Whole Foods. So this is the experience of a lot of people who have food insecurity and households that have food insecurity. So the main aspects of that are access, financial resources. So maybe if budget wasn't an issue, he could buy that really expensive bag of apples. Also, the quality of food. So there might be fresh fruit and vegetables available at your local food outlet, but the quality is poor, not something you want to eat, or maybe it's not even safe to eat. And the most severe form of food insecurity that we're most concerned with is reduced intake of food. So this predoctoral student, he could have, maybe there were some oranges or something he could eat instead. But he wanted an apple. That was his preference. A lot of people are experiencing, though, a lack of access to really any food and disrupted meal patterns, which just means skipping meals because of lack of access, or not even eating for a whole day. So we have been surveying food insecurity in the United States for over 25 years now. We have a survey that is administered nationally in December every year. It's called the U.S. Household Food Security Survey Module. It's a big survey. It has 18 questions. And it's really the gold standard for measuring food security at the population level. And what researchers have done in the past few years is whittle this survey down into just 2 questions. So it's a brief screener for food insecurity. It's called the Hunger Vital Sign Panel. And the 2 questions shown here comprise this brief screener. So what I want to point out here is that this first question covers more of the lesser severe aspect of food insecurity, which is worry and anxiety over accessing food. But then the second question covers more of the severe form of food insecurity, which is, like I mentioned, disruption in food intake, and also this financial strain of not being able to afford more food. This 2-item question is now starting to be implemented in the clinical settings because the larger survey is just too burdensome to do in the clinical setting. Here's some updated prevalence trends of food insecurity, which, as you know from news outlets, food insecurity drastically increased in 2020. I want to show you a couple things here in this chart. So the Healthy People 2020 goal was to decrease food insecurity to about 6% of US households. We can see in 2008, related to the Great Recession, that food insecurity spiked. And it spiked to the really high levels that we haven't seen in a long time. And those high levels were sustained for several years after, until recently, food insecurity started to decrease in prevalence and rate. And then COVID hit. The dotted orange line there represents the expected food insecurity prevalence for 2020. It is based on some surveys, but we're waiting on the USDA official data to come out. That will come out in September of 2021, and we expect that data will confirm these kind of preliminary surveys of food insecurity returning to really about 15% of all US households. And households with children, you can add another few percentage points onto that for prevalence. It's even worse. Risk factors for food insecurity include low income status, unemployment, right? So those get at the financial strain or financial resource component of food insecurity, disability, chronic illness, and now COVID-19 infection. So households with a COVID-19 infection in 2020 were at a higher, had a higher risk of food insecurity. Households with children, more mouths to feed, more resources needed. Single female-headed households, Black and Hispanic households, and urban, rural, and predominantly Black and Hispanic neighborhoods with not very many food outlets. So basically living in a food desert. The racial and ethnic disparity.
There was a question from Nicole.
Okay.
So Nicole asks about the vital signs survey captures whether people have money, like it focuses on money to buy food, but she was wondering how do you capture people who get food from food banks or need to get food from food banks where money isn't required? Is that rolled into that screener, or how do you get to that question?
So that is not specifically included in, it's not teased out in that brief screener. So the screener does not really allow for the complexity of asking about food insecurity as much as the bigger survey does. But even the bigger survey doesn't ask about where people are getting their food from. There's a lot of stigma around getting food from food pantries or receiving SNAP benefits to acquire food, or even getting food from friends and family. And this isn't really accounted for. So if you're able to get your food and sufficient amount of food, a lot of people do rely on food banks and food pantries, then you might consider yourself to be food secure because you are acquiring foods. But if you're not able to access the type of foods that you want from the food pantry, then you might consider yourself still to be food insecure. So it really depends on how that individual feels about whether or not the food bank or food pantry or however they're accessing their food is sufficient for them. Takes away that worry and anxiety, whether it lasts throughout the month, things like that. So yeah, I think that just let me know if that doesn't answer your question.
You're good. Thank you, Rebecca.
Oh, thanks, Nicole. And okay, so racial and ethnic disparities are huge in food insecurity. Native Americans really are bearing a huge brunt of this problem, as with other chronic diseases. Black and Hispanic Americans and families are more than twice as likely as whites to have experienced food insecurity in 2020. This is a big problem. So food insecurity is bad because it's linked to poor health outcomes. And one of the major mechanisms is through reduced nutrient intakes. So food insecurity affects individuals across the lifespan. Okay, it's not just an adult problem, it affects children, it affects pregnant women and seniors the most. It has the most detrimental effects for those populations. As we can see with children, iron deficiency anemia can be a result of reduced iron intake. Tooth decay, can be caused by poor diet. For adults, diabetes, hypertension, and seniors, a lack of protein is big for them. So we can see how food insecurity leads to poor nutrition, which then can result in poor health. So this has been a problem. Food insecurity has been a problem for a while in the US. There have been a lot of initiatives and programs developed to combat food insecurity. Currently, there are 15 federal community-based programs to combat food insecurity. And they do work. So the science and the literature shows that they do decrease food insecurity. They improve health outcomes, but food insecurity is still a huge problem. 1 in 4 Americans actually participates in at least one program, one federally supported program a year. Some of those are shown here, represented here with their emblems. So SNAP is the Supplemental Nutrition Assistance Program. It's used to be known as the food stamp program. So that provides financial benefits for people to purchase foods. WIC is the Special Supplemental Nutrition Assistance Program for women, infants, and children. So that provides financial assistance and some guidance and regulations around the types of foods that can be purchased with that money, as well as a little bit of nutrition education. We have a lot of child and senior programs. So the National School Lunch Program is one. There's the major focus, though, with these federal programs is on food access, and not enough focus on nutrition education. So food access obviously is important. So that's supported with financial assistance or actual providing food, like through the school lunch programs.
Rebecca, I have a question.
Yes.
So earlier in your slide about the prevalence of food insecurity, your top value was 15%. But here, when you say 1 in 4 Americans participate in one program or more each year, so that's 25%. So why are those two numbers not closer together?
So they're not closer together because these programs are working. So when someone is a household's participating in SNAP, they are improving their food security. So that might help somebody move from reporting being food insecure to food secure. So just because a family is receiving SNAP or WIC benefits or participating in the school lunch program doesn't mean that they are food insecure. The goal is that they would become food secure.
Okay, makes sense.
Yeah. Yes. And I also just want to point out that half of SNAP participants are children. So there's some misconceptions about the SNAP program, but it's a really important program. for improving food security. So these federal programs can't function without partnerships at the state and local level. And there's lots of different sectors participating. So schools is a big one, health departments, nonprofits. So locally here we have like Gleaners Food Bank, and churches is another strong supporter of these programs. So I just want to share quickly a little bit about some work that I did on investigating some of these community programs. And I specifically investigated the SNAP education program. So it's the smallest program, federal program in terms of funding and participation, but it's a really powerful program, and I'll show you why. So during my PhD, I designed and facilitated a study to do a randomized and controlled community trial. And we partnered with SNAP education. So I had 40 SNAP educators at the county level throughout the state volunteer to help me with the study. And then I also had buy-in and partnership with the state SNAP ed leaders, whose offices were conveniently located across the street from my office. So that was helpful. And I got to know them really well, which was nice. So for my study, we did a one-year follow-up period. The intervention was 4 SNAP education lessons. And these were just those core lessons that are considered to make up the program. We had a control group who had to wait a whole year until after the study to be able to take the lessons. And then we had an intervention group that received at least the first 4 lessons. And just to orient you with this graph here, the scale is 18 because I used that full USDA, US Household Food Security Survey module, which has 18 questions. And that allowed me to be able to stratify the population, my study population into the entire household, and then also into adults in the household, and then children in the household. So I can take a look and see how child household food security was different from adult household food security, and then the entire household, which was pretty eye-opening. But we can see here on the very left side that the study population of people who were interested in receiving education and were also eligible for SNAP, their food security was low. So they were teetering between very low food security, which is the most severe, and low food security. And then we can see over the 4 to 10 weeks, while the intervention group was receiving their education lessons, both groups kind of had a improvement in food security. But then the most interesting result here was this sustained improvement in the intervention group, so that green line, across an entire year after taking the lessons. So having those lessons helped people to be able to maintain their food security over an entire year. And this is a really strong study because we can see that the control group regressed back to their baseline levels of food insecurity. The results were that the SNAP education lessons allowed the intervention group to improve their food security by 25%. Which is huge. And these were all households with children in Indiana. So the answer to the question is yes, SNAP education does improve food security. So that study was such a success, I wanted to do it again. And this time investigate whether SNAP Ed improves diet. And the goal of SNAP Ed is to help participants to align their dietary behaviors with the dietary guidelines for Americans. And so food security is just kind of like a secondary benefit of the program. So the main thing is it's a nutrition education program. So shown here are the scores for my participants who are circled here, stratified by food secure and food insecure. So food insecure are orange and food secure are green. And the healthy eating index is just, it's a measure of how well people are adhering to the dietary guidelines for Americans. And the total score is out of 100. So it goes from 0 to 100. And we can see that that bottom blue line there is the US adults average score, which is around 48. So as a population, we have a ways to go to improve our diet in accordance with our federal guidance. SNAP recipients on average were a little bit lower than the general US population, and theirs is around 45. In my study population, who again are people interested, low income population interested in receiving nutrition education, even within this group, it's not homogeneous. We have a mix of most people were actually food secure, and their dietary index was much higher, significantly higher than those who were food insecure. So this is highlights a really important need that we need to acknowledge that even within a low income population, some people are doing fine in being food secure, but those who are food insecure are really at risk for detrimental nutrient deficiencies or low intakes of important foods and nutrients. So I've shown you that these community level programs are pretty effective in at least improving food security. We have some work to do on diet. And also, so we did do this over the 1 year period, and we didn't see any significant changes in diet or so in nutrient intakes or just diet overall. So this is just kind of the average, a snapshot of that. So we need more approaches. We have to cut into other sectors. We need help, basically. The community level approaches we can't do it on our own from there. So in the past few years, there has been a lot of momentum and support from professional medical and health organizations. So you can kind of see some quotes over here from the American Academy of Pediatrics and the American Academy of Family Physicians. There's tools that have been developed to assist clinicians and other healthcare providers in the clinical setting to assess for social determinants of health, food insecurity being one of them, as well as start to connect patients with resources either within the healthcare institution or in the community. So there's a couple here shown here. And I kind of want you to think about clinicians out there on the call today. What are, and you can type in the chat too if you'd like to share, but what are some ways that you currently are thinking about food insecurity or social determinants of health in your patient population? How are you starting to address it? If at all, or what are some of your concerns? What are some supports that you need in order to be able to do this more effectively? And And so along with the support of encouraging clinicians and healthcare institutions to address social determinants of health, we also have a lot of emerging research. Over the past few years, the literature has exploded on this topic. And I think leading the field is definitely the Siren Center out at the University of California in San Francisco. So if you're really interested in this topic, check out their website. It's really excellent. So with this emerging research, there was a need to provide a framework to guide not only the research, but to guide the implementation of activities around addressing social determinants of health, and any one of those specifically. So a national panel of experts convened at the National Academies of Science, Engineering, and Medicine and produced this report. And the most important thing I think that came out of this report is this framework for strengthening healthcare and social care integration. And so this framework is a little bit, it kind of builds on itself. So we start with awareness. And this is, I have it highlighted in green because this is where most of the institutions, healthcare institutions that are beginning to or have implemented approaches to addressing social determinants of health in the clinic are at. So this awareness factor, like domain, covers, it crosses both the community level and the patient level. And we can think about awareness as activities that assess need. So screening patients for social needs would be one, maybe doing like a needs assessment at the community level would be another one. So it's really just getting a handle on what is the need, what is the prevalence of the need, what is the what are the attitudes and perceptions of both clinicians and patients toward addressing these needs, and what does the clinic's population look like in regard to these needs. And then once that's kind of we have a handle on what the population is looking like, we move on to adjustment, and that is just adapting patient care to accommodate for the social needs. So that might be, learning that your diabetic patient is accessing most of their food through a food pantry, and maybe having a conversation with them about what kinds of foods are they getting, and how could they optimize those foods to support their chronic disease management. And so that's at the patient level. Assistance is also at the patient level. And that's kind of the next step up, is working with your patients to connect them with community resources, or maybe even just institutional healthcare, resources within the institution. And then we get more into the community level with alignment, and that's kind of a little bit higher level. That involves the healthcare institution to start partnering with community organizations to start building like synergistic partnerships across the two sectors. And then of course we have advocacy as kind of the last piece after we go through these other domains, is for the community organizations and the healthcare organizations to work together to create and implement policies that support the activities in all of these domains. And so this framework is really great because it kind of allows us to compare across different studies. There's a lot of kind of individual interventions going on at different institutions. Some institutions are way ahead, like they're at the alignment level. But this allows us to sort of have a more concerted and maybe scalable approach to the social needs, addressing social needs in the clinic. So the literature shows basically that clinicians are pretty receptive to addressing food insecurity and other social needs in the clinic. However, there are some concerns. There's some barriers shown here, like a lack of what to do with that data or knowledge that your patient is food insecure. Lack of time, unclear roles, like who should be responsible for screening and going through those activities in the framework with the patients. Discomfort, it's a really sensitive topic. You know, a lot of times patients and participants, they don't want to answer these questions or talk about it. So some facilitators that we have found through the literature that are helpful are building trust, also like training residents or just providing some training on how to talk about some of these social needs has been helpful. Buy-in from leadership, both in the healthcare institution, but also the community organization levels. And we have shown, I think, already through the literature that screening is feasible and it can be successful, especially through the existing EHR workflow. It's just, we're not really sure what to do always with that data. And I want to show this picture, I just want to explain really quickly, is actually a SNAP education client from Indiana, from Daviess County. And she is, I love this picture because it really just shows the essence of nutrition education and how important it is in the approach to improving food security. And it's an often minimalized aspect of the approach. So this woman is showing her son how to make a fruit smoothie, basically. And the education that this experience she's sharing with her child is powerful because it's shareable. So this woman can share this knowledge of maybe how she learned how to budget her food purchases, do meal planning to make meals on a budget, use different types of ingredients in thrifty ways. And that information and knowledge that she has can be shared not only with her child here, but also with her other family members, with her neighbors, and with her clinician or with her community members. She will have that knowledge forever, and she can share it with whomever she wants, versus just the provision of financial resources and food is temporary. The nutrition education, it's long lasting. So I think my point is it really needs to be part of our solutions. So this leads me to my career development grant proposal. And the goal of that is to understand how federally qualified health centers who serve a predominantly low income and medically underserved population, how they are implementing efforts to address patient food insecurity. And by efforts, I just mean those activities that I talked about from the framework of integrating social needs and healthcare. So to start off, I'm predominantly focusing on just that like food insecurity screening, so that awareness phase, and food resource intervention, so like that adjustment and assistance phase. I have 3 aims, which I'll go over in the next couple slides here. So my first aim is to conduct an environmental scan. So right now there's not any literature on what FQHCs are doing as a whole to address food insecurity. Some FQHCs are implementing some initiatives, and some are just doing like the bare minimum, which is screening. And we don't really know to what extent either that these are occurring. These efforts are occurring. So I want to survey and interview a purposive sample of FQHC leaders across the US, and just get an idea and understanding of what are the barriers to facilitating these efforts, and then what are some of the facilitators that are encouraging them or supporting these efforts. And then the next step of that would be to look locally and work with Eskenazi Health to do a really deep dive into their efforts, and use, so this 1B will be like a mixed methods approach, because I'd like to extract the INPC data and see like which Eskenazi sites are doing food security screening the most, like which clinicians are doing a lot of screening, and kind of learn from those trends, and then do some interviews with the clinicians and stakeholders with that data, informing those interviews. So from this aim, I hope to really understand in the FQHC setting in primary care, what are those factors that are influencing efforts to address or not address food insecurity. I also expect that I will be able to identify some additional factors that are not in the literature currently, that will be important to take a look at. And then like especially around data structures. And then finally, just have a deeper understanding of how Eskenazi Health approaches patient food insecurity. They have a lot of really amazing programs right now, and I think a lot of those could be tied to food insecurity. For aims 2 and 3, I'd like to design and pilot an intervention. And so Eskenazi Health will be the study setting for that. We will work with stakeholders and clinicians, and then also our clinical and behavioral research experts here at Regenstrief and Indiana University to come up with an intervention that can be tested for feasibility, and something also that could maybe be scaled to other FQHCs and maybe even nationally. So since this is part of the K, the purpose would be to get an intervention ready to test in a larger R-level funding grant. So to do some efficacy testing in some kind of larger, more rigorous trial. Eskenazi is the best place, I think, to do this type of work. They're already implementing food insecurity screening. That should be fully implemented in a few months. I just wanted to show you just some preliminary data out of Eskenazi. So food worries Here, about 31% of the population that has been screened so far is reporting that they do worry or have anxiety about running out of food. And then 25% of those who have been screened report running out of food or money before they have more money to buy more food. So this is definitely a problem, a big problem at Eskenazi Health. And with their existing programs, like their nutrition education programs, their lifestyle behavior programs, the screening, the data structures that we have, I just think that this is going to be a really successful setting for this project. So I am finishing up my postdoc program actually on Friday. So I just wanted to give you an overview of what I've been working on. I've been doing some grant applications, some publications, lots of presentations, learning about grant writing and things like that. So I think I've been developing a lot of skills to make me successful to pursue this research. And before I open it up to questions, I just want to say thank you, and acknowledge all of my mentors and collaborators. I couldn't list actually everybody, so these are just kind of the main projects I'm working on, but a big shout out to my mentors, my formal mentors. I have so many mentors here at Regenstrief and IU, but I just want to say thank you so much to these people shown here that have been guiding me through the past 3 years, and hopefully will continue to do so throughout my career. So part of the K is also further training. And so some training I want to do is in get some more experience and expertise in clinical trials, health behavior interventions. So traditionally I've been in the community setting, and now I'd like to build some more skills to investigate and do research in the clinical setting. It's a little bit of a different skill set. And then qualitative methods, I want to be able to run some focus groups and interviews effectively. And so I have some training to do there. In the future, this research, I think, is heading towards this theme or this notion that has come up recently in JAMA of nutrition insecurity. So traditionally, we've really thought about food insecurity as a financial resource problem. When we're thinking about food insecurity in terms of health outcomes, I really think that we need to focus more on the nutrition and diet aspect. And so I see this research moving into more of those questions that Nicole brought up in asking about food more specifically, in order to be able to not only improve food security, but also improve dietary behaviors along with that to ultimately improve health outcomes. Precision nutrition, just like precision medicine, is also gaining momentum. I think that a lot of these kind of community and social factors that I've talked about and interested in studying can play into that precision nutrition research area as well. And then also this clinic community partner health information exchange builds off of work I've been doing with Titus on clinical health information exchange. I think we need to move more towards being able to exchange information across sectors. So there's a lot of work and research to do there. And just some final thoughts here is how do we get people thinking about nutrition? You know, medical students, residents, and fellows, they're interested in nutrition. Let's get them more engaged. Partnerships, we need stronger partnerships across different sectors. We have a lot of great local partners here in Indianapolis, so I think that we can really start to model that for other settings. And then good research leads to policy change, and ultimately that's my goal. And then I've also been thinking about some other research settings. So I'm really focused on the FQHCs and Eskenazi Health right now, but after talking with some researchers in the past couple of weeks, I think the VA is definitely an opportune setting as well for this research. And so with that, I just want to say thank you and open it up for some questions and discussion.
Thank you, Rebecca. Great talk. We have quite a list of questions in the chat. So what I'm going to do is I'm going to call people in the reverse chronological order. When I call on you, please unmute yourself. You can even share your video if you are so inclined. So we'll start with Greg's question about some of the mechanics of doing what you just talked about. Greg.
Thanks, Titus, and thanks for a great talk, Rebecca. My question was really about where in the clinical team and primary care some of this work might be best situated. And as you were talking about surveying what the primary care providers do, I was thinking about other areas in which we actually take things out of the hand of the busy primary care doctor and find ways to have other staff members do screenings or trigger things like flu shots or cancer screenings, and actually have better traction than just leaving it in the hands of the doc. Do you have any thoughts about that with food insecurity?
Yes, thank you for this question. This is a question that needs more investigation. So far in the literature, physicians specifically don't seem to be the best people or part of the healthcare team to do the screening and referrals. They're very busy and they have a lot of other things to deal with. So this is a big question. Whose responsibility should it be in the healthcare team to screen for and follow up on treating food insecurity? And we don't know. This is an area of active investigation. And I think that Eskenazi Health is a really great setting to start to explore these roles and who could best support patients in meeting their food security needs. Some thoughts that I've had or directions that I'm thinking of going with this are, maybe at check-in, or maybe patients could fill out a screener through their patient portal. A lot of patients aren't participating in their patient portal. I know there's some initiatives to get more people signed up for that, but there's a lot of different touch points, I think, and those are just some that I've thought of. I'd like to get into the clinic and just really ask around and try some approaches out and see what works best. And it might be different setting to setting, whose role it should be.
I'm going to pick on Josh here for a second, because if I remember, Josh, you have food insecurity in upstroms. And the other thing that I think I remember you saying the other day is that the physician actually doesn't use upstroms at Eskenazi. It's really kind of assistance or something like that. Can you shed some light on that?
Yeah, so I agree with Rebecca Oliver's discussion on who should be using it and questions. I would say a couple things is one, it depends on when people are looking and screening. She's right, there's a different preference for patients to ask who wants to, they wanted to have this conversation with. There's a difference in providers on who they want to, who wants to ask about social risks and needs. I think I saw a thing in the chat that there is a section in Epic to document this. They actually have the Children's Health Watch screener questions that Rebecca mentioned. They're not super easy to get to from my perspective, but they're there. We've to some of the thing is it depends on some of the workflows we've worked with has been other types of providers doing it, whether it's a nurse or a social worker or even dietitian looking up. And I think I appreciate definitely what Becca brought up about what are you really measuring, the distinction between like nutrition and health. And like when Sarang and I first started this work, we found out that we actually were probably more predicting people who needed dietary changes versus people who, needed food. And there's a distinction between somebody who has, as she alluded to, immediate health need versus secure food insecurity or bad diet. And so those are like getting that construct right can be a definite challenge, as she mentioned.
Good points, Josh. We got 4 more minutes. I'm going to pick on Brian and then Jasmine. Brian, if you could ask your question about documentation real quick.
Yeah, so my question is, how well are FQHCs, documenting FIS in their electronic health record systems? So Josh kind of alluded to this, but I'm curious because I've heard rumors that it's better than the private sector. There's no evidence on that. And so I'm wondering, your thoughts around that and if that could play a role in your research going forward.
Yeah, so that is something that I would like to survey as part of that environmental scan. I don't think we know how well they're doing it, documenting. They're supposed to be, but I would like to investigate that further.
Jasmine, your question. I don't know what Z codes are, so I'm really interested in your answer.
Yeah, sure. And I actually provide care in an FQHC, and so have a little bit of perspective to add to this. But with the Z codes really being used to identify social determinants of health and being a really kind of tangible way to document social determinants of health, Epic at Eskenazi also has the social determinants of health wheel that shows progress towards or severity of the social determinants of health. I think Eskenazi, just anecdotally, is making a lot of efforts in the right direction at documenting not only food insecurity, but also the other social determinants of health. And so I think the Z codes provide a mechanism not only for documentation, but also begin to explore the idea of reimbursement, of resolution of the social determinants of health. So I think the Z codes are vastly underutilized in practice from a nationwide level, but there really is an opportunity to build a better structure for documentation of Z codes and resolution. And one of my comments was just that we need to do a better job at documentation. And the Prepare tool really does have really nice, the Prepare toolkit actually has a lot of framework and suggestions on how best to do it. But from my perspective, I don't know that health systems are doing it effectively at this point. But I think that there are the tools in place to use it. And from my opinion, I think community health workers are in an ideal position to help be that person who not only documents the social determinants of health, but also provides resources to facilitate the resolution of the social determinants of health or issues related to the social determinants of health, and to take that burden off of the primary care provider and onto the community health worker who would be working one-on-one with the patients, I think is an ideal position.
Yeah, thank you for those comments. That's really interesting. I definitely going to look into those Z codes. I agree with everything you said too. Also, the community health worker model is really has a lot of potential. And we have community health worker systems here in Indiana too. So that's definitely something that we could explore.
Okay, cool. We are at the end of time. Thanks everybody for being here. Please keep your questions and comments coming to Rebecca. Her email address is right there. Grab a screen snapshot and you got it. This is exactly the kind of input and interaction that we need. I think it's a very potential rich space that Rebecca is attacking here. And obviously we got a great environment for this. So thanks everyone for coming, and please be in touch. Bye.
Thank you, everybody.